Hi, I'm going to present my audit on CPET guided risk stratification for colorectal surgery. So what happens in our local setup in Sheffield Teaching Hospital is we refer patients who are greater than 60 years or if they're younger with some significant comorbidities to CPET to risk stratify their cardiopulmonary, to assess their cardiopulmonary status and risk stratify accordingly. What we had in our mind when we started our audit was to answer two questions: whether we need to adjust the indices to reflect the outcome of our local population. We currently use York's criteria, which MUO of greater than 15 anaerobic threshold of greater than 10. We classify them into high risk. And the second question which we had in our mind was to see whether women needs to be assessed in a different criteria rather than just following the same for men and women. What we did, we retrospectively looked into patients who has risk stratified and went on to have their operation between 2014 to 2018. What we looked into length of stay post-operatively. We couldn't exactly find it, so we used surrogates like the resurgery and complication rates, which served as the marker for immediate morbidity, and we looked into 2-year mortality as the marker for intermediate mortality. When we analyzed the data, what we found was quite interesting. Across all the years, we stratified more percentage of females into high risk than the percentage of into males. So we went on to do some subgroup analysis. What we found out was the anaerobic threshold was significantly lower in female compared to male. So this lowest anaerobic threshold value in female made us to stratify more number of female into high risk group. If you look at the physiology of difference between male and female, we can understand the reason why there is low anaerobic threshold in females. When we applied odds ratio to establish this claim a bit more further, we found out that the risk stratification seems to be quite appropriate in male, whereas in female, the 2-year mortality had no significance between high risk or intermediate group. So therefore, we conclude we need to change the criteria to cater our local population, especially in females, considering the physiology and metabolic demands. Thank you.